Welcome to The Pharmacist RN, a podcast made for pharmacists by pharmacists. Pull up a seat and let's get started.
The pharmacists are in and the pharmacists are back. I'm Ajit Johal and this is John Papastergiou, and this is the final part of our three-part series on respiratory diseases. And today we're going to talk about respiratory syncytial virus. See, I said that.
RSV.
RSV, I did.
Heard it say that, but you know what? We were talking in the green room here before we went live, and I was saying, do you think it's too much? We've done too many immunization segments in a row, but I think it's important. And I think when, the next big thing, I think for pharmacists is going to be RSV vaccination, I think, in this space. And we've seen a lot of talk, we know a vaccine's available, another vaccine's coming. We'll talk a little bit about that. But, the question I want to start it off with is, why now? Why RSV? And how come we hardly ever heard of this?
It's a great question. So I just want to track back and say, this is part of the complete story.
Yes.
Right. This is the reason why we have all these episodes together, influenza, COVID, pneumococcal, RSV, is we got to think of this as the full story.
Yeah.
And it's great that we're talking about RSV to kind of wrap this up. And the reason why we haven't heard about RSV, well, RSV has been around since the 1950s. It was actually a disease in chimpanzees. Fun fact, John, did you know that?
I didn't know that.
Walter Reed Institute in Pennsylvania saw an outbreak of the chimpanzee-like Corzilla virus, and it was thought to be an exclusive chimpanzee disease.
And to the audience, I'm sitting in the studio here. He's not reading that from anything. The fact that you know that scares me a little bit.
It's a fun fact.
He's pulling that off. Like, he doesn't even have notes. He's
just straight off the top of my head. Back to Walter Reed Institute.
Yeah.
It was thought to be a chimpanzee virus, and then it was found to cause infection in humans. And then it was categorized as respiratory syncytial virus. And it was predominantly an infection at that time classified in infants, which it still is. It's still a huge problem. Infants showing up in a hospital in the first year of life. And the reason for that is, do you know why it's called RSV? It's the syncytium.
No.
So the syncytium is the name of when a multinucleated cell all gunks together. And so what RSV does with its fusion proteins is it starts to pull cells together. And it forms this multi-bulky mass, which serves no other purpose but to cause inflammation and disease. And with babies, they have small airways. So they have tiny straw airways. That causes a lot of respiratory distress. So we see, belabored breathing, we see cyanosis, blueness, and that causes a lot of distress to parents who, my newborn baby can't breathe, and that prompts a medically attended visit. So RSV has been categorized to be a disease in infants, and it's also a disease in older adults. Yeah. So just like I was saying, the babies are small, they're frail, their lungs are small. As we age, our immune system ages with us. And with that, we also have limited lung elasticity. So older adults just as at risk for COVID, influenza, pneumococcal disease, and RSV. But to circle back to answering your question, John, is we never tested for this thing. No. We accepted that this disease circulated, it caused illness, and it was, monkey, hear no evil, see no evil is happening. So there's no testing. And I think the biggest evidence of that is that when we look at reported cases of influenza-like illness, some studies show that at least 20% of that is RSV. So influenza got credit for RSV. Isn't that crazy?
Yeah, no, and you're right. And I think, because if we went back 5-6 years ago and you asked pharmacists, I think this was predominantly thought of disease in kids.
Oh, yeah.
Amongst pharmacists. I think in the acute care settings in hospitals, there was some testing being done there, and they would see it. But I think in the community,
for kids, they do.
It wasn't anywhere on the radar. And I'll tell you, the tech has changed, and I'm not going to get too far off topic, but we have the ability now in some point of care sites to test for these acute infectious diseases. We've got an ID now running in my store, and I can see it when we get into certain times of the year and we start testing you'll see it'll be, you know, influenza. That's what patients will, but all of a sudden, you know, 2, 3 weeks will go by and now you've got RSV. And you can actually
Yes,
see what's circulating, eh?
it's
Like,
incredible.
and we can see those trends, and it's because we offer quite a bit of the testing. Obviously, that's not routine, but my point here is that when you do test, you actually see it in the community. And now I was approached actually by a company from France a couple of weeks ago, and they've got technology that's coming, folks, where it's just one swab, you
That's
throw it in,
incredible.
and now you see the whole gamut of
Yeah,
infectious
yeah.
diseases, and you can see exactly what the patient has. So although we weren't armed with this knowledge in the past, it's coming and it's coming very quickly. But I think your point is it's not just a disease of children or young children, but it is a concern in older adults.
It is, yeah. And I think there's a second part of the story of why we don't hear about it. Even if we do test for it, what are we going to do?
That's it.
Right?
That's it.
What are we going to do about it? So it's like the only treatment is supportive. Now, there's still a lot of value in the testing that you're saying for two reasons. One is antimicrobial stewardship,
Yeah.
right? So if it's viral, you know, to the patients, and you even see this when you do your
Yeah.
strep testing, is if it's viral, the patient still, they're not going to take the doc's word for it. They're not going to take
Yeah.
your word for it. Yeah, I think it's viral. You know what? Screw it. I'm going to take the
Yeah.
antibiotics. But if you actually definitively say, this is a test, it's viral, that helps, but then you got to do some more education too.
Yeah, of course. I got a student working on this right now. And because we've got the ability to test, you know, we're testing these patients that come in with new prescriptions for antibiotics for respiratory infections. And we're finding exactly what you say. A large percentage of these scripts are not bacterial. They're viral. And it's not because the physicians are ill-intended. And I think I may have even talked about this on a previous segment, but it's because they're telling the patients if they swab for strep or something, you know, take this, I'll call you in a few days, tell you you
Mhm.
should fill it. And what these guys are doing is they're coming in and they don't feel well and say, I'm just going to fill the script.
Yeah.
But when we test, now I've got my student or my staff pharmacist, they still want to take the antibiotic, but you've got to now sell them on the idea that it's doing nothing.
Yeah.
And it's actually potentially going to do more harm to you and society as a whole.
Well, I think that's actually a couple global initiatives. I was at ID Week in Boston last year and went to a couple antimicrobial resistant talks. And what we find works in developing countries is you almost need to give that sort of non-antibiotic prescription, that information sheet, like you're saying. So maybe that's something
Oh
that,
yeah, very important. Yeah, it's
yeah.
something we could probably start as this becomes more widespread. Yeah,
Yeah.
it's something that I think we should be doing. And the other thing we talked about the difference between, you know, the infants and the adults. The other key point here is although it was very common in infants, the infants generally recover and do well. That's not the case with the adults, right?
Yes, you're absolutely right. So that's actually Ontario data you're
Yes.
citing is that infants have a higher chance of being admitted into hospital. So it hits the news, right?
Yeah.
In BC Children's Hospital, we see lineups
That's right.
coming out. Probably in Ontario, you got sick kids, right?
The kids,
Yeah. And CHEO is the other one.
Yeah,
Yeah.
some kids.
Just try to flex my Ontario geography skills. But what actually people don't know is that older adults, even though less likely to be hospitalized for RSV, more likely to die.
Die.
Yeah, more
That's
likely
it.
to die.
And
1 in
it's-
9.
And yeah, and it's,
Crazy.
you know, that's high, you
Yeah.
know, and I think whenever you hear about respiratory illness, it doesn't matter if it's COVID, influenza, now RSV, if you make it into hospital, around 13% of these patients die.
I know.
It's high.
It's high.
Yeah, so
That's
I
very
mean,
high.
the good news is we can do something about it.
We can do something about it for both vulnerable
That's
groups,
right.
for infants and older adults. So let's just quickly run through the pipeline very quickly. We'll start with the younger infants. So two options available. The first is a monoclonal antibody,
Yeah,
nirsevimab, also known as Beyfortus, that was approved in April of 2023. And that's administered to the neonate, typically before the age of 8 months,
yeah,
at birth if they're born within RSV season, or
Right.
just before the RSV season. And what that does is you can't immunize a baby that young
yeah,
because their immune system is not mature enough to seroconvert. So if I
Yeah.
present an antigen to you, John, or someone presents it to me in a shot, our antibodies can seroconvert and start making antibodies to
Yeah.
that. But babies don't have that infrastructure. So we got to put the antibodies straight in,
Yeah.
right? And when we do that, now they have circulating antibodies to fight RSV. So,
But what if we were to immunize the mother?
so that's the other strategy, John. That's the other strategy where if you vaccinate the mother, and we do this for pertussis,
Yeah.
right? So pertussis, also known as whooping cough, we get a transfer through the placenta to the baby.
Yeah.
Yeah. So
two
strategies.
options
Yeah.
there. So what does Nancy recommend?
So you're gonna love this. So NACI does have a preferential for the monoclonal antibody, and there's a couple reasons for that. The first was when we looked at the data. So the Matisse trial talks about the maternal immunization, and the Melody trial is nirsevimab to the newborn. But long story short, better efficacy data in the nirsevimab trial, as per NACI's interpretation, and proposed longer durability.
Yeah.
So, the waning of that protection, because the first year of life is really the critical window. As kids get bigger, their lungs get bigger, they get a little bigger, so they do better.
Yeah.
So that's the reason why NACI recommended nirsevimab as a preferential. But there is a twist, classic NACI, M. Night Shyamalan twist.
Yeah, and this is why I serve these questions on a platter, because I know there was a twist coming, and
You
it
knew
really
there was a
irritates
twist.
me, this one.
The twist is nirsevimab is preferred, and then you would do maternal immunization if there isn't a way or an availability for nirsevimab. But the only way that they recommend nirsevimab be available is if the manufacturer drops the price by 80 to 90%.
So that is ridiculous. That whole recommendation to me is. I remember when I heard that for the first time. We were at an airport somewhere, and I think you were there. And I had heard it. You guys had heard it, but I had heard it for the first time. And I'm like, this is the most ridiculous thing I've ever said. It's like, yeah, this is recommended, but give it up for free. It's not going to happen.
Yeah, there's a lot of contingencies on that. So
that being said, what's our other option?
So I think our listeners want us to be as practical as possible, and what we were doing earlier was impractical.
That's right.
So as practically as possible is the tool at your disposal as a pharmacist, or even I would argue as a primary care physician at this point, is the Abrysvo vaccine. Has a dual indication for maternal patients between 32 and 36 weeks gestational age, and for older adults over 60, and same with Arexvy. We'll talk about Arexvy because we have experience administering Arexvy, which is another vaccine for older adults. But to summarize, Abrysvo should be available in June, so that is an option that will be available for use in maternal patients, for your patients who want to protect their future neonates against RSV. Now, if things change, which they do, this is the time of this recording, it'd be nice to have nirsevimab administered in hospital, administered by public health, but I haven't heard any plans.
Yeah, and let's practically speaking, that's not happening. Because the administration's going to be the issue as well. Where's that going to be done?
It's an implementation strategy that hasn't been discussed. So long story short, there's an option to protect newborns against RSV. A couple options available, but practically should be seeing some Abrysvo.
The other thing is, who names these vaccines?
It's a good question.
Yeah, they're too sound alike, in my opinion.
Yeah,
this is a potential for errors
we don't want that.
No, and I think it's already started. There's been examples of maternal patients getting the wrong vaccine, right?
Yeah, so there have been some reported cases of that. So I always tell pharmacists, take a look at the product monograph. Have both, so Arexvy and Abrysvo. Currently, Arexvy has been available since September. October. It was approved in August 2023. Abrysvo was approved in December of 2023, but it is currently not in distribution at the time of this recording, which is May 9th.
Yeah, not here in Canada.
In Canada. In the US, it is available. Yeah. So
that's just a watch out.
Yeah.
It's coming in
Lookalike drugs.
Classic. Yeah, they're not interchangeable. It's not the exact same drug. I think that's very important.
Yeah, and I think the important thing is the Abrysvo vaccine was studied in pregnant patients, which is not the case for most of the vaccines. No. Even the ones that are highly recommended, we don't have these robust randomized controlled trials where we monitor the health of the infant for up to, I believe it's 2 years post-vaccination, which is quite generous for monitoring. Yeah. But that's the Matisse trial, and I think over 7,000 pregnant women enrolled, which I think is a great data set. So that shows the vaccine's safe and effective.
So that's the kids.
That's the kids.
We,
Yeah.
we talked about that first group, and I think there's a few pearls there. But now, most pharmacists are focused on the older adults.
Well, that just goes with all of the vaccines we've been talking about: influenza, COVID, pneumococcal, RSV, older adult patients, comorbidities, right?
Right.
They're older, they're taking medications, they're seeing you. So no nasty statement yet, but the CDC, the Advisory Committee on Immunization Practices, has weighed in, and they recommend via shared clinical decision making either the Arexvy or the Abrysvo vaccine for older adults 60 and older. So 60, I love an age cutoff.
Yeah.
An age cutoff makes it clean. If your patient's 60 and over, talk about RSV.
That's right.
Simple as that.
Really simple, right?
Very simple.
Yeah, so the guidance is simple. What I question now is, again, how many pharmacists are doing this yet? I think, the information's starting to get out there. I know there's a lot of effort being made on education. There's a lot of, talks for community pharmacists. Now it's time for action, right? Get out there, make those strong recommendations. You own those patient relationships. We've seen the success we've had with co-administration of flu and COVID and other vaccines. Let's get the word out on RSV.
Let's definitely get the word out for RSV. I kind of want to reflect, because I practice in British Columbia, so our scope is, sorry, John, a little bit more latitude. I know that Ontario recently got the authority to administer the RSV vaccine.
We were a little delayed.
A little delayed just to administer the vaccine. It's crazy. So someone asked for it, or even if they brought in a prescription, you'd be like, I'm sorry, my hands. That's crazy.
It's the way the legislation was written here. It was a little short-sighted, but every time a vaccine comes out in a new therapeutic space, we have problems, because you can't just start doing it.
Just didn't begin with the end in mind, right?
No, that's exactly it.
So being from BC, all vaccines are Schedule 2. We can dispense and administer without a prescription. So I've got a really interesting story about the first RSV season. So RSV season, for our listeners, is similar to flu season. It starts October, November, and it ends probably about now, April, May. So going through the past RSV season, given that my pharmacist and myself do not need a prescription for this vaccine, we ran a little study. And I know you appreciate that, because you're very big on your practice-based, pragmatic trials. So I'll give you the story. The first thing I did is I administered the Arexvy vaccine, that's the GSK, the adjuvant to RSV vaccine, was approved in August 2023. The first doses we were able to order was September. And I actually, just like you, John, like to lead by example to my pharmacy team and the province. And I administered the first 2 RSV vaccines in the province. Yeah. It wasn't the first in the country, because Alberta had that in long-term care, but I did the first 2 in the province. I posted that on LinkedIn. My pharmacist saw it, my colleagues saw it, and I said, you know what, I recommended this vaccine. It was a couple that I met at a conference I was presenting at, Seniors Living Conference. I was actually presenting about flu. So it all starts with flu, doesn't it? Always. Lung disease begets more lung disease. And so they actually said, yeah, we read about the RSV vaccine in the New York Times. And what I want to say, especially to our Ontario listeners, is that being able... So this is for our Ontario listeners, John, is that a lot of this RSV vaccine that we observed in our pragmatic study was patient-driven. So someone is coming up to you being like, I heard about the RSV vaccine, I want that. Yeah. And if you say, yeah, go talk to your doctor, chances are they won't get it.
Lost opportunity.
Huge lost opportunity. So to make a long story short, 250 vaccines administered in the first RSV season, 85% prescribed by pharmacists.
See that's a
mic drop.
Yeah, that's what I call a good news story for the profession, right? Like, when you're able to showcase the value of the pharmacist and what they could do in a new therapeutic area and do it quickly, and I think a lot of the work that I've done has been around that, being able to show that and get that out there and hopefully inspire other pharmacists to do the same thing. And I think kind of that's what we are now, is really trying to kind of get some momentum going in this RSV space. And I know there's going to be a lot of questions around the vaccine, and one that comes up all the time is it every season? Do we give one dose?
Durability,
right?
yes.
That's important, right?
Very important.
So what do we tell our patients? Because inevitably they're going to ask that, especially if they're paying out of pocket.
If they're paying out of pocket, and that comes to the value of vaccination. And we talked about, it's funny, and if you haven't listened to the episode yet, the COVID segment of the COVID influenzas, people are tired of getting a vaccine, and even though it's publicly funded, it's just like they just can't be bothered to roll up their sleeve. But someone's proactive, they're paying out of pocket, and they're saying, do I have to pay? I don't know how much it is in Ontario, but it's close to $300 for the vaccine. Do I have to get this every season? Do I have to pay $300 every season? Now, what I tell patients is there's no booster recommended at this time. So far we have data readouts from 2 seasons, at least 2 seasons, where there's no revaccination recommended. So the current guidelines say it's a single dose immunization. That could change. That's why I say there's no booster recommended at this time. But I'll kind of give a bit of a nerdy explanation as to why I think that the durability of this vaccine is so good, is because our ability to make natural antibodies to RSV is very poor. We actually my colleague, I don't know if you know Zane Chagla, but he's huge educator. Yeah,
of course.
Phenomenal speaker, great educator, very knowledgeable, infectious disease specialist. He said something to me that really resonated, that we were talking about older adults, talking about the high risk of mortality. Is that older adult patient you've seen now admitted with RSV, and now they're, having issues with their lungs and whatever, that's probably their 19th or their 20th RSV infection. So we are constantly reinfected by this virus across our lifespan, and where it really does us in is either in the first year of life or when we're older. And the takeaway is that we don't make antibodies to this very well naturally. So the vaccine, and this is the, 1957, Walter Reed, yes, we're going back to the chimpanzees, is the reason why the vaccine took so long to develop is finding that target or that epitope, right? Pre-fusion. Yeah. Pre-fusion, and it's the F fusion protein, but not just the F fusion protein, it's in this pre-conformation state. So just before it binds to the cell, it's very hard to isolate. You have to crystalline that structure. You got to do an amino acid substitution with I think it's proline, because it's bound to its own backbone.
No one knows what you're talking about.
Yeah, I know, right? So basically, that is the key, is when you get vaccinated for RSV, you have very good neutralizing antibodies, and that's a lot better than what you make naturally. So 2 seasons, maybe more. I tell my patients, this is the investment you're making now. You're protected for at least 2 seasons, probably more, and there's no booster recommended at this time.
And then I guess the other question we get is there a best time to give it then?
Yes. Yeah, sir.
Important, right?
No,
because you want to maximize time too, right?
Yeah, and I always say the best time to immunize is the opportunity when the patient's in front of you.
That's right.
And you can prescribe. Sorry, John.
Yeah, that's right. So, we can't do that. But that's what, I've heard different answers to that question, depending on who you use. Some people say, do it in the middle of respiratory season, because then you're maxing out, the cycle. But we don't really know how long this is going to go for anyways, right? So I don't know if that's the best approach. I agree. If you've got someone there that wants to get vaccinated, do not turn them away.
Definitely. And I think realistically, John, at the end of the day, when are patients coming in asking for this? It is during the season. Yeah. So anytime during the season, even if it's at the tail end, because they're still going to get that season, and then it's going to reload for the next season, and probably the season after that. But we also talked about some patients who are coming up time and time again, patients who ask about flu shots early, right? So one thing I actually wanted to mention is that the epidemiology of flu is, with the pandemic, it kind of got all messed up. It's slowly shifting back, and when we look at the southern hemisphere, that kind of gives us an idea. COVID actually, last year we saw more cases in August, if you recall.
Yeah,
so it's a little earlier, right? So RSV, it's unpredictable around that time, but the point I'm trying to make is the one thing that is said is when we're getting our flu shots, right? So we have patients, many of whom are keen and are at risk, who say, hey, John, or hey, Ajit, when are flu shots available? Yeah. Well, flu shots will be available when I have no idea, because distribution leaves it to the last minute, but RSV vaccination, do it then, because you're very close to the start of the season. And then, of course, snowbirds. Yeah. No brainer.
Yeah, people traveling, all that stuff will come up. But like we said, and we talked about it before, use that opportunity, because it's unlikely that you're going to be able to give people 3 and 4 shots in the middle of flu season. It's safe to do it. You can do it. But that's a whole other conversation.
You got to be a very confident immunizer, which I'm confident our listeners will get to. And you got to have time.
Yeah.
Right? It's you got to pull that vaccine out, pair it.
Yeah,
So
it interferes with the kind of the slick workflow that you got going at that time of year.
it's a throughput game.
Yeah.
You got people lined up, but you know what's good is it's a longitudinal game with these patients.
Yeah.
You want your high risk patients to get refills of their medications, coming in for their subsequent vaccines. Shingrix is a great vaccine for this because there's 2 doses.
That's right.
Right, so you can start. I usually build a plan around that.
Yeah.
There's a lot of overlap with these vaccines, and that kind of brings me to a point I want to summarize for those of you who stuck with us through all 3 episodes. Very entertaining, and with the new theme music,
so yeah,
it's next level.
Next level. We got our own theme music.
Yeah.
First episode, we hit top 5% of podcasts. That's an achievement on its own.
It is. Oh, it
not
totally
many
is.
podcasts will hit that level so quickly. I mean, we were there pretty much within 48 hours. So it's going to be interesting to see where we can take this. Our audience continues to grow.
Yeah.
We're thinking of some innovative, kind of things to do with the podcast and subsequent episodes. And we've said it before. If you've got any ideas, you want us to talk about some things, put it in our LinkedIn, comment section, and we'll try to tackle some of these issues because
we want to know what's affecting your practice, what you're seeing, because that's very important. And I think like the final summative point here is Kanye West's new workout plan.
That's right.
Your new immunization plan. New immunization plan. There's so many great options now. We didn't even get to talk about shingles.
No.
That's a whole new episode. But for respiratory disease, you said it best, lung disease, or your colleague said it best. Lung disease begets more lung disease. COVID, influenza, pneumococcal, RSV. Powerful, powerful tools at your disposal to make healthier patients.
Let's make a difference, guys. We'll end it at that. Thanks for tuning in. Thanks.
Perfect.
Now